moving now to the third session, which will be about connective tissue diseases. So there will be 5 abstract presentations. I hereby request Dr. Rakesh Mondal sir and Dr. Tapas Sabui sir once again to chair the session. Request Dr. Sushma Shree to kindly come forward.
Good afternoon, everyone. I'm here to present our study on comparison of nail fold capillaroscopy findings in juvenile dermatomyositis before and after treatment. As we all know, vasculopathy is common in juvenile dermatomyositis, and these changes are evident in the nail fold capillaries. Nail fold capillaroscopy is a highly sensitive imaging method used for analyzing the morphology of capillaries in the nail fold region, and this has been very well established in systemic sclerosis and bushy capillaries, which are relatively more specific to dermatomyositis. NFC, nail fold capillaroscopy density, has been very well studied, and its association with disease activity is known. And also the number of hemorrhages has been attributed to the dysphagia that is present in the juvenile dermatomyositis. Our research question was to know if there are any changes in the size of the giant capillaries before and after treatment in the children with juvenile dermatomyositis. It was a prospective observational study conducted in Bharati Vidyapith Medical College and Hospital, Pune. The cases of juvenile dermatomyositis registered in outpatient department were enrolled in the period of January 2022 to August 2023. They were all newly diagnosed. Diagnosis was based on clinical diagnosis with muscle weakness, characteristic cutaneous features supported by muscle enzymes, and whenever required, MRI of thigh muscle. They were all treatment naive, and clinical assessment of muscle weakness was performed using childhood myositis assessment scale. Laboratory parameters including muscle enzyme, creatinine phosphokinase by ELISA was recorded at the beginning and at the end of 12 weeks. Standard of care treatment was initiated. Nail fold capillaroscopy images were captured on 2 occasions at the time of diagnosis and 12 weeks later. We did this using the software Inspectus. It had 200 times high resolution optics, and we followed the standard procedures of acclimatizing 20 minutes prior to the procedure, and also all 8 fingers excluding thumb were screened, and each finger an area of around 3 square millimeter was screened. Nail fold capillaroscopy parameters studied included capillary density, number of bushy capillaries, size and quantity of giant capillaries, and giant capillary was defined as the apical diameter of the capillary more than 50 micrometer. And follow-up changes were recorded at the end of 12 weeks. The total number of cases were 9, 6 boys and 3 girls, and mean age at diagnosis was 6 years. And the myositis specific antibodies were positive in 6 of them. We tested 7 of them. 1 was we could not detect, and 2 we did not test because of financial constraints. TIF1 gamma was the common one in 3 of them, followed by NXP2 and SAE. And mean duration of symptom was 3 months, and the mean CPK baseline was 2,444, and mean CMAS at baseline was 32. As we can see in this table, in children who have attained remission, as also evidenced by an improvement in the CMAS score, there is a decrease in the size of the giant capillaries. And also, surprisingly, 2 children who had increase in giant capillary size without any clinical flare proceeded to have a flare around 1 to 2 weeks later. The mean capillary diameter was 65 micrometer, and mean CPK value was 1,152. Mean CMAS score was 28, and independent t-test for CPK, that is the change of CPK before and after treatment, was significant, and the capillary diameter size change was also significant, and but we did not find the change in the density significant, but the number of bushy capillaries was also significant, and the change in the CPK values, which after excluding 2 values which were outliers, we were able to see that it also correlate, the coefficient in change was also significant. In children who had presented with flare, capillary density was reduced. There were increase in capillary diameter and number of bushy capillaries. In children who had attained remission, the largest capillary diameter was found to be reduced. And in 2 children who were in clinical remission, as also by CMAS, NFC showed increase in capillary diameter, which was followed by clinical flare after 2 weeks. And this showed that NFC changes were dynamic, and it predicted the disease flare. To summarize, In our study, we have quantified the nail fold capillaroscopy changes with in children with juvenile dermatomyositis. We have recorded the creatinine phosphokinase and childhood myositis assessment scale. There are multiple studies on capillary density correlation with disease activity in juvenile dermatomyositis, but our study also showed that the diameter also correlated with disease activity. It adds that the NFC changes are dynamic and may predict the disease flare. And this reinforces the need for serial NFC in children with juvenile dermatomyositis. Thank you.
Any question from the audience? In your study, all capillary was observed by single observer?
Yes, sir. It was a single observer study, sir.
Sir, may I? Yeah. So, do you think this has a statistical significance? Do you think your sample size is adequate?
The sample size is less, sir.
And did you do a correlation with the different activity parameters, skin activity separately and muscle disease?
We did not do
the
that,
CMAS?
sir, but we correlated it with CPK, but there were two outliers. After excluding those two, the change in CPK and the correlation with NFC changes were significant, sir, but it was low significance. By ELISA method, sir.
All in all?
All children had diagnosis and after 12 weeks.
No. All had raised CPK.
Yes, sir.
How much?
The mean value was 2004. 1 second. Mean CPK at baseline was 2444.
Okay, thank you.
Thank you.
Next one.
Thank you, Dr. Sushma Shree. So next I would like to call Jigna and Bathia.
Good afternoon. I'll now be presenting our preliminary one-year data on the Indian Childhood Lupus Nephritis Registry. So we all know that renal involvement is the most important predictor of mortality and morbidity in SLE. So keeping this in mind, the aim was to develop a registry so as to prospectively evaluate the clinico-epidemiological profile, biopsy findings, treatment and outcome of childhood lupus nephritis from multiple centers across India. So, it was a prospective analytical multicentric study endorsed by ISPN, which involved 10 centers across India. The study population was children less than 18 years of age who were diagnosed as SLE as per the SLIC criteria and biopsy confirmed lupus nephritis. We had excluded those patients who were drug-induced lupus and those who were mixed connective tissue and those who had problems in communicating at the required interval. Renal outcome was defined as complete remission, partial remission, no remission, and deterioration. The one-year analysis was, out of the 162 patients who were enrolled, 60 patients had completed 1 year. So these are the patients whom we are analyzing at this stage. The median age was 13 years and the male-female ratio was 1:3. Extrarenal manifestation most common was mucocutaneous, followed by hematological, then musculoskeletal. The time of renal manifestations since the disease onset, half of them were at disease onset, then another third within 1 year of disease onset, rest were within 1 to 5 years, 5 to 7 and more than 7. Renal manifestations, as we did the left 4 parameters, the most common manifestation was edema, followed by hypertension, oliguria and gross hematuria. And the right 4 that we see, the most common was nephrotic range proteinuria in 72%. So the other 28% was subnephrotic range proteinuria, followed by AKI, then microscopic hematuria. The mean EGFR was 87. The class of lupus nephritis that we saw, the maximum 38% were class 4, followed by class 3, 4 plus 5, then class 3, followed by class 2, and then class 5. Management that we gave, 83% had received pulse methylprednisolone, along with around 50% received first induction with MMF, and another 45% received first induction with cyclophosphamide. 2 had received rituximab, and 3 did not receive any induction. And maintenance, majority of them had received MMF, whereas 3% did not receive any maintenance. The final outcome at 1 year, complete remission was 70%, partial remission was 22%, and no remission was seen in 8% of the patients. There were 3 patients who were in CKD and 9 children we lost. We did a small preliminary analysis because the treatment was very individualized. So we saw that amongst MMF and cyclophosphamide, comparison of severity of findings, we did not find any difference in severity of nephrotic range proteinuria, median EGFR, activity index or chronicity index in terms of choice of therapy as first line. Coming to outcome of usage of first line MMF versus cyclophosphamide, the only significant finding was using MMF as first line immunosuppressant. The need for second line induction was significantly less if used MMF. That is 6% versus 27% in cyclophosphamide. And we also did a very basic analysis of complete response and no response predictors. We did not find any statistical significance, but the numbers are still very small. So we hope that as the further analysis goes on, we will have the further numbers. These are the 10 institutes that we have enrolled. Thank you.
Good collaborative descriptive study. You have said that 9 child died out of 42. Is it quite fine or high or low?
It's actually, sir, the 60 patients that we have included, it is still, actually there were 100 children, but only we had complete data of 60 patients. So it's 9 out of 100 we would say, but it is quite high.
What is the cause of death in this child? Cause of death?
Cause of death.
On those child?
Cause of death.
Cause of death, some of them were infections and one was CKD.
In your cohort, this AKI rate is about 73%.
Yes, sir.
It's very high.
Yes, sir.
Why? What's the reason in your cohort?
Sir, it is just a finding of a collaborative registry. It's very difficult to comment why, because what the other centers had, we don't know.
Any question from the audience?
Out of the 62 patients, none of them received maintenance as Azuran. Everybody received.
Yes, this particular registry patients did not receive Azuran. If like from our institute, we do use Azuran, but not in this particular registry. At least the 60 patients of 1 year analysis, we did not have any Azuran use.
That means in 7 centers, the study has been done, no one uses Azuran.
Not this lot of patients, no, sir.
Okay, please next one.
Thank you, sir.
Thank you, Dr. Jigna. Next up, we have Dr. Gaythri CV.
Very good afternoon, one and all. I am Dr. Gaythri, DM resident in Pediatric Clinical Immunology and Rheumatology from PGH Chandigarh. I am going to present on the topic, renal biopsy without a full house effect. Think of lupus with a monogenic defect. So renal biopsy remains the gold standard in patients with lupus nephritis, where the characteristic feature is full house pattern in immunofluorescence. Though the etiology of lupus is poorly understood, now growing evidence support monogenic causes of lupus. However, the diagnostic role of renal biopsy is still yet to be studied. So this study was done with an idea to determine the diagnostic role of renal biopsy in identifying the etiology of lupus. This was a retrospective review of records. And patients with monogenic lupus were enrolled from 2015 to 2024. And all children with lupus who underwent renal biopsy in the year 2022 were taken as control. So patients classified as lupus by SLIC 2012 and EULAR ACR 2019 criteria who underwent renal biopsy with genetically confirmed monogenic lupus and with suspected monogenic lupus were enrolled. So the suspicion of monogenic lupus was made when 3 or more of the following criteria were satisfied. So in our cohort, 7 out of the 18 patients with monogenic lupus underwent renal biopsy. The median age of onset of symptoms being 4 years and the youngest child presenting at 6 months of age. The male is to female ratio being 5:2. The hematological involvement, mucocutaneous involvement, and the pattern of ANA were comparable in both the groups. However, in the monogenic lupus cohort, there was significant family history, infections and lymphoproliferation, global developmental delay and intracranial calcifications were again seen only in the monogenic lupus cohort. Hypocomplementemia, which was seen universally in all patients with the non-monogenic lupus, was not universally seen in this cohort, with amounting to less than 50% of all patients. So this is a representative histopathology image. Here we can see the mesangial hypercellularity, and also this is the Jones strain with the Mason's trichrome counter stain. We can see the basement membrane thickening. Another image showing mesangial hypercellularity and also the vial loop lesions with basement membrane thickening. So on comparing the histopathology features, both the features were comparable in both the groups with almost similar distribution of various classes of nephritis. On comparing the indirect immunofluorescence, we saw that this is the classical full house effect, where there is deposition of IgG, A, mu chain, and light chains like kappa and lambda, and complements like C3 and C1q. This is the classical full house effect seen in lupus. We saw that in some patients there was defective stain of IgG and C3 as seen in this image, and some also had defective IgM stain. In the monogenic lupus cohort, we had 7 patients, and 5 of them had definitive underlying monogenic cause which were pathogenic and explaining the underlying etiology of lupus. 2 of the patients showed various variants of uncertain significance in the clinical exome sequencing, and these patients are still under evaluation. So on comparing the immunofluorescence finding, it was seen that in all patients with non-monogenic group, all patients had full house effect in indirect immunofluorescence. However, in the monogenic group, more than 70% of patients did not show full house effect, and they had absent immunostaining for more than 1 deposits. So, and the treatment outcome were comparable with in both the groups. On reviewing the literature, it was found that multiple case reports have been published so far with monogenic cause of lupus, and the renal biopsy showing defective staining of 1 or more deposits. So in 2021 from India, a DNase2 defect was reported where C3 staining was negative. Again, in the same year from Turkey, another DNase1 ligand 3 defect report was reported, and they had defective IgA and IgM staining. From India, again, a child with ACP5 gene was reported. She had negative staining for IgG, C3 and C1q. In 2024, a child with Noonan syndrome was described where IgM staining was defective. This study now describes 7 patients with monogenic lupus, 5 of them having confirmed genetic mutation, and more than 70% do not show full house immunofluorescence. So it might be concluded that majority of the patients in the monogenic lupus cohort did not have full house immunofluorescence, and they showed absent staining of 1 or more deposits. So anything less than a full house immunofluorescence may be a pointer towards an underlying monogenic cause. So identifying the underlying monogenic cause may help in personalizing the treatment, which might include fresh frozen plasma or JAK inhibitors, and also include hematopoietic stem cell transplantation. I would like to acknowledge my mentors and guides and my fellow friends and all the nursing officers and lab technicians for helping me do this study. Thank you.
Good. But it's a retrospective study.
Yes, sir.
7 patients
Yes, sir.
who actually have biopsy and monogenic lupus. We have to continue and then to conclude because the very less patient, only 6 or 7.
Yes, sir. I agree that it was a retrospective study, and we, though 7 is the maximum numbers published so far, we have the number of sample sizes less to conclude the same evidence. So we would like to collaborate with the other centers to extend the data, extrapolate the data for adding further strength to the study.
In the previous study presented, this was the biopsy incidence only on 30%, I think. And you are saying we'll have to asking to do biopsy in all cases.
No, sir. No, sir. Only in those who were clinically indicated, where clinical indication of nephritis is there, where clinical indication of renal biopsy is there. Only then, only in those patients we had done biopsies. And yes,
so nice work. I just wanted to ask that what you actually have shown that in the non-monogenic lupus, all your class 4 nephritis is non-monogenic lupus. You did not find a single class 4 biopsy in your monogenic lupus. If you go to your table, that would clearly show that the monogenic lupus actually has a much milder degree of nephritis. And that is why you see less of immunofluorescence in them. You can easily see from there. You don't need to go to the immunofluorescence to say that if you don't have full house, then you should look for monogenic lupus. I mean, that message is not a correct message. I mean, there will be many biopsies, even on non-monogenic lupus, which will not have full house. They may have 4 out of 5, which you will have staining. So I don't think that message can go. That looking at the biopsy, immunofluorescence, you can say that you should suspect monogenic lupus. It is the other way around, that monogenic lupus has a milder lupus nephritis, generally, in general. You just go to your table, you will see that there is no class 4 nephritis among your group of See here, even the mixed 5 class 4 nephritis are all in non-monogenic lupus. There is not a single class 4 in your monogenic lupus. So that has a very milder disease.
Ma'am, many had class 3 and 5 nephritis and they required cyclophosphamide induction also. We are just trying to retrospectively see whether it could help in identifying.
Well, your number of cases less, so maybe class 4 is not seen in that group. But madam's view is also correct. Thank you.
Thank you, Dr. Gaythri. Okay, I thank all the presenters and esteemed chairpersons of this session.